So welcome everyone to our first NAO lecture of 2023. I'm Sarah Allen, Director of the North American Observatory on Health Systems and Policies and Associate Professor here at IHPME. And it is my great pleasure and privilege to be welcoming our Honorable Capri Cafaro. She's honorable because she was a state senator, elected official in the state of Ohio, and has since become a lecturer at American University in Washington, D.C., and has previously taught a workshop in University of Toronto and American University before the pandemic, and has since been teaching comparative US and Canada policy to AU students, and so is very well positioned to come and tell us about what's going on with long-term care policy in the United States, but also to start to draw some of the lessons for Canada, and has that perspective on both sides of the border that's really unique and will be a great addition to our NAO series and will lead to some rich discussion today. So we have people in the room, folks joining online on Zoom, and we will be recording. Actually, have we put recording? Yes, thanks, Monica. We're recording this so that we can post it on our YouTube channel, and we'll share the link around and we'll publish it on our website. So I will turn it over to our honorable guest and we'll, without further ado, and so we're just going to swap seats so that you have a good image of our speaker. And so just mind the bit of some noise on our end, but we will switch over and I'll turn it over to you.
Thank you, Sarah.
Welcome.
Hi, good morning. Thank you, Sarah. Thank you for those of you that are joining on Zoom, as well as, I'm going to tilt this down a little bit because I am short and it needs to happen. But I really do appreciate everyone that is attending and for your interest in this lecture about long-term care in the United States. So as you can see, I'm going to be touching on a handful of aspects about long-term care policy, delivery structure, funding, and ultimately policy gaps, to which there are many. As we find that our demographic shifts in many developed nations, particularly the United States, Canada, and the United Kingdom, the three countries that I'm most familiar with in this space, while systems are slightly different, some of the underlying challenges are the same. So I'll go ahead and get started, and I know we'll have some time for questions as well. So this is as an example here, the United States and the United Kingdom face similar demographics, and you can say the same thing for Canada. Growing aging population, certainly baby boomers, when people are retiring every day, people are living longer. And so that certainly creates a real challenge to the long-term care system. You certainly have some challenges related to health outcomes driven by racial and ethnic disparities, and the social determinants of health. Because of some of these, those two factors, you're seeing an increased demand for long-term care services, increased demand for mental health services. And when you have an increase in demand, obviously you're also going to be concerned about cost. The more people that are utilizing, and frankly, because people are living longer and you're dealing with, complex comorbidities, conditions, things like Alzheimer's and dementia, these are more costly when you're dealing with healthcare, and long-term care delivery. And long-term care is not just nursing homes, okay? It's also, home and community-based services. And so there is, what we call a continuum of care, that exists in this space too. So there's a lot of strain on the system, but also budgetary constraints. As well. I mean, you have state and federal budgets, provincial budgets as well, that are limited. And you also have workforce shortages, which I believe Sarah actually did some work on that aspect, particularly in the context of the pandemic, wage competitiveness. So, it's a perfect storm. We're really in a very difficult and challenging position for policymakers to figure out what to do. So this is just to show here that, the population in the United States is continuing to grow in the cohort of 65 and over. And in places like my home state of Ohio and a good portion of the industrial Midwest, you see that population of the oldest old over 80 growing even faster. So you have pockets of the country and you know, I would surmise it's very similar in certain provinces in Canada. So in places like the Maritimes in Atlantic Canada, where you have a larger aging population than you do, you know, in maybe a place like Alberta or BC, you know, we have similar issues with geographically in our concentration of older individuals as well as the oldest old, and that rapid population growth. And again, in some of these states, you have this other perfect storm where you have an older population, an aging population. What does that mean? It means that people aren't necessarily working. They're not necessarily paying into the system. So you have a higher percentage of, you know, poverty, lower income individuals, again, creating strain. So cost, it's pretty significant. So you think about we also want to talk about formal versus informal care. So as I mentioned, you know, long-term care is a very broad term when it comes to this sector of, you know, healthcare and social service delivery. So not only are there a multitude of types of care in long-term care, like I said, home and community-based services, you know, community supports, institutional care, so to speak, but there's formal and informal care. And, you know, just to place this in a little bit of context personally, I actually started my career in aging policy. And part of the reason why, 20 years ago, part of the reason why that was because I was part of an informal care giving system as a family caregiver to my grandfather who had Alzheimer's. And so all of us, you know, pitched in. And, you know, my uncle moved back into the house because he didn't have kids. And my mom was taken into the doctors, you know, and my sister was at college. So, and I was back. So, you know, she was like not necessarily part of the catchment group, but everybody else in like that was remotely local was playing some kind of a part, whether it was driving people to the doctors, getting food, picking up meds. You know, and as he got older and sicker, you know, we did have some extra help from, you know, a service, but we did it pretty much ourselves. So informal care is real. And that's a $470 billion value of uncompensated care. And people, you know, they leave their jobs sometimes, particularly if they're, you know, providing informal care for a spouse, a family member, a child, for example, that may have complex needs. So that's something that we don't really talk about. We talk more about the formal care, you know, which is, you know, skilled nursing facilities, assisted living, home health. And that is a huge, you know, price tag, $339 billion average annually. But what I want to focus on is, you know, that's a big number, but let's break it down because, you know, the government is paying for some of this, but frankly, individuals are paying for a lot of this because in the United States, as it is in Canada, it's really a patchwork of who and how things get paid for in the long-term care space. States do carry most of the load, which I'm going to talk about more extensively, but that is, you know, a means tested program through Medicaid. Medicare, which cares for individuals over 65, pays for very little, and that's on the slide too. But just to touch skilled nursing facilities, $92,000 a year, $92,000 a year. So, you know, almost $1,800 a week. These are US dollars. I mean, that's significant, you know, and that's how people end up selling all of their assets, liquidating their assets to keep, you know, their loved ones in a skilled nursing facility. Why are SNFs more expensive? Because again, you're dealing with more complex needs, higher acuity levels, and therefore it's going to cost more. Assisted living, $46,000 a year. It's kind of that, again, when you're looking at the continuum of care, right? You know, we kind of think, oh, that's like the sort of the hybrid model of individuals that might need a little bit more support. Maybe it's not totally safe for them to be on their own at home. You know, so there's like a button in the room, you know, they have, you know, on-call nurses, more socialization, you know, physical activity type stuff, you know, a little bit more of a retirement community setting. But the tricky thing about assisted living is that like 99% of that is private pay. In the United States, you can't, that Medicaid in certain states have applied for waivers from the federal government to allow Medicaid to cover assisted living. It's very rare. The assisted living facilities themselves have to become certified and apply. So you can't just be like, yo, I'm on Medicaid, I want to go into a facility that's close to me, like, you know, so we have a couple of these that are like literally in between, like where my grandma used to live and where I live, for example. And if she wanted to go into that facility, it didn't take the Medicaid waivers. So it's not just like the money follows the person, the facility itself has to be a Medicaid facility too. So it makes it that much more complicated, but still very expensive. So home health is by far the least expensive model at $31,000 a year. So what we see more and more is this shift towards home health care, home and community-based services for two reasons. One being cost, and the other being, you know, this concept of people wanting to be at home, you know, self-determination, independence, you know, and allowing people to make that choice if that's what they want to do. Quick bit on Medicare and Medicaid. As I mentioned, Medicaid, you know, it's you know, together between Medicare and Medicaid, it's about $242 billion. So you see of that $339 billion that I mentioned at the top, 72% of that is Medicaid, and Medicare. Medicaid has, by and large, has to pay for institutional care. Medicare has all kinds of different stipulations. So again, Medicaid is means-based. So, and there are all kinds of rules around assets. So, and the federal law changed back in 2005. So you can't just, you know, say, for example, like my friend whose mom just had a brain tumor removed and they were having all these fights about keeping her in the facility longer under Medicare to just get her physical therapy and her occupational therapy. But really, you know, it's 40 days, that's it. She doesn't qualify for Medicaid because the Medicaid is, again, a very, you know, significant threshold, it's very limiting threshold from an income and asset test. But they didn't know she had a brain tumor, right? And she's over 70. So they're not necessarily planning to liquidate assets. Plus, you know, the dad is still around, and or they put him on the street, right, by like selling the house. But you have to, it's 7 years. You have to plan 7 years in advance to get to liquidate your assets in order to qualify for Medicaid. Medicare, again, very limited. And then finally, our private sector payers, long-term care insurance. It's a very, very small amount because a lot of people don't have it. People aren't thinking about it. It's very expensive. And frankly, by the time you need it, your insurance company might be gone. So, I mean, if you're like trying to like sign up for long-term care insurance in like your 20s or 30s, like we pay into Medicare, you know, and Social Security in the United States, starting from when you work, right? You pay it's payroll tax deductions. If we were to do something similar to that from a public perspective, which is something that they did, you know, propose actually in the Affordable Care Act that got axed because they said it was going to be too expensive. That would be one way in which they could create basically a long-term care trust fund at the federal level that would be portable. And, you know, conceptually, at least it would still be there as opposed to, I don't know, United Health, long-term care insurance. They could fold by the time you need it at 75. So a lot of complex issues, a lot of costly issues. Oh, come on. So I mentioned this here, Medicaid is the primary payer for long-term care, right? So Medicaid, for those of you who are unfamiliar, it is a state federal partnership. It is one that is funded and administered together between the state and federal governments in the United States. The states really drive this train. This is an older slide, obviously, but it's here just to show you the trends, and the trends have not changed. Medicaid for long-term care services and support. So that's everything. That is home and community-based services. That's, institutional care, both skilled nursing facilities and assisted living. But the, 20%, as I mentioned, is this Medicare post-acute care. And that is that very limited, you are getting discharged from an inpatient hospital to a Medicare, to a nursing home for post-acute care, for rehab. So like my grandmother did this when she had heart valve replacement. She had to go do that. She also did that after she got her hip replaced. But again, Medicare they only paid for, she only needed to be in there for like 2 or 3 weeks. But that's really all. You pretty much only get like less than a month out of Medicare. And then, of course, as I mentioned, so there are other public and private. So, and I'll show this in a later slide. States, as well as local jurisdictions in the United States, have stepped up by raising tax dollars to augment and supplement a lot of the long-term care supports, including and particularly when it comes to some of these community-based needs. So Medicaid, again, can cover institutional, hospice, home and community-based services. And the thing with Medicaid, as I mentioned, it being a state federal partnership, the federal government sets sort of basic standards that the states need to adhere to, or else they could jeopardize their funding. So the federal government says you have to cover skilled nursing institutional, but home and community-based services are not required. So this is one of the reasons why Medicaid is like the big dog when it comes to nursing homes, because they have to. It's their job. However, home and community-based service is not required. But if you recall from like 3 slides ago, home and community-based service is much more cost-effective. States needing to cover institutional care, the best way to curtail and control the budget related to skilled nursing facilities and institutional care is to keep people in home and community-based services for as long as possible at a lower price point. But again, it's not an entirely nefarious cost-containing, reasoning. It's also down to the fact that, more and more, people want to be at home, and there are opportunities to be able to keep people. You don't just have to like be in a nursing home because maybe you have trouble getting around. And as I mentioned with some of these local, levy dollars, for example, they then also will come in and help, because we talk about home and community-based services and aging in place as the industry, this, sector likes to call it. That's all well and good, but you don't do that in a vacuum, right? You have to have adaptability in your home, so where is that money going to come from? Maybe you need a wheelchair ramp. Maybe you need, an adaptive bathroom, or maybe a kitchen, whatever. Those things cost money too. Transportation, adult daycare. So these other community supports, and this is where states and local jurisdictions are trying to find alternatives to be able to augment, because it's one thing to pay for home health care, but then, the quality of life and independence is not there if you don't have these ancillary supports. So, like any Medicaid program, as I've mentioned, the eligibility criteria, because the states have so much latitude on eligibility specifically, those do vary by states. But they're still driven by the income and asset limitations. And I've already talked about the fact that, you might need to spend spend down, or get rid of your assets to be able to qualify for Medicaid. So, states, again, and this number has pretty much stayed stable. 46% of the long-term care budget for Medicaid is on home and community-based services. So this is, I think, another thing that people we often, when we talk about home and community-based services and long-term care, we focus on older adults. But really, a lot of the population is non-elderly and disabled. In one way, shape, or form, whether it is, a physical limitation, mental or cognitive limitations, impairments. So this is very, very, very important for individuals that may have special needs that are not elderly to be able to remain in their homes and be as independent as possible. And we would get testimony, after, witness after witness in the Medicaid committee of individuals that, have some form of limitation or disability, and they would say, this is so important to our independence. And it really is. So, this population should not be ignored. They're very, very important. And this is very, very important to them. Medicaid, again, home and community-based services is more than the institutional services. And as I said earlier, that's by design because they are trying to invest more in home and community-based services as a way to curtail the significant amount of money that has to be spent on institutional services. Dual eligibles, those that are on Medicare and Medicaid. So those are usually the sickest, poorest, and oldest beneficiaries. They're also the most expensive. So as you can see here, so it's about 1.5 million, and that number continues to grow. In skilled nursing facilities, again, these individuals are in skilled nursing facilities because they have oftentimes more complex medical needs. Duals are 40% of the Medicaid expenditures. So, and as I mentioned before, the disabled community as well as the developmental disability population is included in this as well. So again, driving this point home, what is home and community-based services? It includes home health and personal care services. Again, it's not just about, changing bandages or getting blood pressure or vitals or, these kind of things. Personal care services are very, very important. Bathing, toileting, and you have to, in order to get these services, you have to, have a limited number of ADLs, activities of daily living that you are able to do on your own. So, it's not just, willy-nilly, but these things are very important. Because without your ability to have someone to assist you in dressing or toileting or bathing, you're just sitting at home. I mean, so you have to have these augmented services. The number continues to grow. And, generally speaking, it's about little less than $19,000 per beneficiary per year in Medicaid annually in home and community-based services. So Medicare, again, this is the bane of many Americans' existence. And again, Medicare, different than what Medicare is here in Canada. It is for individuals over age 65, as well as individuals with a few complex medical conditions like end-stage renal, for example, and those individuals that receive Social Security disability benefits for 24 months can also qualify for Medicare. So predominantly older adults, but there are others that fall into this category too. So for example, a disabled individual could be a dual eligible on Medicare and Medicaid and not be over 65. So Medicare doesn't deal with they're not paying for you to be in a nursing home for 5 years. They're not paying for, the personal care services and the, other services at home. They are just strictly dealing with medical services, and short-term rehabilitation in a nursing home. But again, you have to be there are tricks to this too. 72 hours in an inpatient facility, an inpatient hospital before you can get discharged to a skilled nursing facility. But the quote unquote 3-day rule doesn't apply to Medicare Advantage. So Medicare Advantage is the private insurance version of Medicare that is administered by private insurance companies and HMOs. And Medicare does pay 100% for the short-term rehab stays, like I was mentioning, my friend's mom, up to day 20, but days 21 to 100, you still are paying, almost $165 a day. That adds up fast. And, so basically Medicare is very specific and targeted in this space. Long-term care insurance, as I mentioned before, about, very few Americans have it. There's all kinds of talk around it. It's very expensive, as I mentioned, and the ACA did try to create this public long-term care insurance model, which I still think is a very valid policy alternative. But it was originally something called the Class Act, which had been introduced like every Congress since I think 2002. So they basically took the Class Act, rolled it into the ACA, but they got repealed because they thought it was going to be too expensive. I mean, because again, but I think it was a voluntary payroll deduction. So it wasn't even a tax increase. You were saying, okay, like take more of my money. But they still decided it was too risky, whatever. I'm very salty about that because I did a lot of work on the Class Act like early in my career, and it just seems so logical and so low risk. And one day what's going to happen is that like the federal government's going to wake up and be like, oh no, we should have done this. But the problem is that, oh, we didn't spend the last 25 years accruing into a trust fund. So you can have, a vested, benefit to deliver, and then it's going to be too late. Anywho, I digress. So long-term care, the living arrangements, just again, most people are living in the communities. So more and more we're seeing that people are aging in place, as we like to say. Sorry, this is a little bit hard to see in Zoom, but I think it's pretty clear here, on the big screen for those of you that are in the room. But it just shows that long-term care services and supports in 2020 was almost 10% of all of the healthcare expenditures in the United States. So that just shows, again, what is this driven by? Yes, it's driven by, cost, but it's driven by an increase in older adults, people living longer, and the baby boomer situation, which is creating a strain on everything. Actually, President Biden just announced today as part of his budget framework, which again is really more of a, directive policy document that never actually happens in the United States. But he proposed, because our trust fund for Medicare is actually for hospitals, much like Social Security, which everybody kind of hears about, has solvency issues because of this demographic challenge of, you have just every day more and more, individuals hitting that 65 number, or for Social Security now it's almost it's 67. You get more and more people in, drawing on those benefits, Medicare and Social Security, and less people comparatively, it's this inverted sort of like pyramid, if you will, that are paying into the system, less people in the workforce because that population comparatively is much smaller. So President Biden actually just introduced something else today, or announced it, about how he intends to try to shore up the Medicare trust fund through increasing taxes on investments and certain types of income over $400,000. So the chances of that happening and being implemented are pretty much zero, but we're having this conversation because we are in a demographic tsunami, which, most countries of, like the United States, Canada, and the United Kingdom, Japan, are all in the same boat. So here's a few things that exist from a programmatic standpoint. So we've talked about sort of the funding structure, But there's other programming and policies around long-term care support services, right? So there's something called the No Wrong Door program, which is actually quite good. And so it's a partnership between a number of different agencies. And it happens actually, it's administered basically at the local and regional level. So it helps people navigate. We had this conversation yesterday in your class, like, there's all this stuff. How do people like find this stuff? Like, how does the average person navigate it? Which is how, frankly, I ended up in this line of work, because I was the only person in my family who knew the difference between Medicare and Medicaid at 19. And so I was tasked with figuring it out. So somebody has to be, and oftentimes there's, you may have this experience in your own family. Somebody is that person, that point person is trying to, tries to navigate the system. You don't have that person in your family. There's the No Wrong Door program that helps try to, collaborate and communicate because there's so many things. I'll give you an example. So if you want Medicare Part D, which is for drugs, and you qualify, you could potentially qualify for a subsidy to help defray the costs, the out-of-pocket costs associated with that. You have to go to the Social Security Administration. Now, if you are on Medicare, that's part of the Medicare program, Medicare Part B, those premiums supports totally different agency. They're administered through Medicare, and that's a Medicare function as opposed to a Social Security function. So how is anybody supposed to know that? They're both Medicare. Why one is administered by the Social Security Administration, the other is done by Medicaid, Medicare.gov, who knows? So this is very helpful, and because it is administered at the local level, those folks know, what programs are available locally and help navigate. There is a social service block grant. This is basically designed, and block grants, as I again mentioned in yesterday's class and Sarah's class yesterday, that over the last 25 years or more, there has been a trend to basically write checks essentially from the federal government to the states in the social service space in particular. And this is no different. So this is really there to help provide community-based care that keeps older adults independent. So the social service block grant kind of, again, helps with some of these other community things. Like I said, they call them, like the personal care stuff. Doesn't support institutional care or anything dealt with by Medicare and Medicaid. So this is really there to plug those holes, that a state might use for transportation, or they might use for adult day, or they might use for, adapting the house, like I was saying before. So here are some examples from back in the day, but again, it's pretty much the trends are all there. So special services, particularly targeted for the disabled population, case management, adult protective is huge. In Ohio, actually, we rely heavily on our social service block grant for the APS. I feel, particularly because of our growing aging population, should invest more of our general revenue fund in this space, but we don't. We rely heavily on this federal block grant, but when you're dealing with, any kind of abuse, neglect, financial, exploitation, all that stuff, APS, it's very important. If seniors are going to live, at home, they unfortunately do, become victims of scams and all kinds of other things. Prevention and intervention, as well as home-based services again. So you can see, and this just shows that, the social service block grant is basically a check from the federal government to the states, and the states, as you can see, not all states do the same thing. They kind of pick and choose, and these are just some of the highlights. As I was saying, about like how different the social service block grants are, they really are there to like plug those holes of needs that aren't contemplated in Medicare and Medicaid. So counseling and supportive services, services for vulnerable and elderly adults, like adult protective services, and even at-risk youth. So it's not that the social service block grant is not exclusive to this space, but it's very integral. However, there has been a decline because it really has not been adjusted for inflation. So this is always a problem. So you're not getting as much bang for your buck. So as you can see, it's a very important, tool for states to be able to augment if they're going to shift towards home and community-based services. Social service block grant can help keep them, keep folks in the community by augmenting those services. But the buying power, so to speak, has eroded over the last, 30 years plus, 40 years almost. So states are picking up the slack. And I was talking about this before. So so a lot of states they do levies, in different ways. They basically are raising revenue through property taxes, sales tax, and so they're trying to get creative. And so you can see there, are a number of states, and Ohio literally, I think we have 88 counties. That's why it's 74 property tax levies. That number does continue to grow pretty much every year. The counties that don't have a senior levy continue to, pass a levy because you have to go to the ballot to do so. So the public has to vote on it. And by and large, the communities overwhelmingly support the senior levies. But so we have them for every county pretty much at this. I think we're up to 80 out of 88 now. Because it literally people will put them on as like a special election because our communities are so desperate to get funds to help support. Again, also because the reason why the states are stepping up, to the earlier point, that the social service block grant is not going as far, so the states have to figure it out. So, I do want to talk about this informal caregiver support. So this is a pretty important area. So there are grants to states to fund these programs to help family or informal caregivers in their homes. They're based on that, but they're formulaically allocated on population over 70. And so this is, really almost more like a lot of it is that navigation, helping those caregivers, but then some of it is about, training, support groups, respite care, which is very, very important. And I've done a lot of work in Ohio on securing and increasing appropriations for respite care. Just additional respite care programming as well, that is available, that essentially provide, and this is really for individuals of all ages. So that's the difference, children and adults with special needs. So, that number continues to grow. 37 states and the District of Columbia do get competitive grants that up to $200,000 to augment this. It does, it seems like it's not a whole lot of money, to be honest, but it is certainly a start and something that is necessary. And it is administered through the Older Americans Act, or the Social Security Act, which would be Medicaid, or basically whatever the state decides. There's another agency that would be appropriate. I just mentioned this, Alzheimer's respite care. We have a pretty robust respite care program that needs to continue to grow. Adult day in home and short-term stays at facilities. We actually did this for my grandfather once because everybody was out of town, like literally nobody was around and it was just me. And so we had him for just like 4 days in a facility, which you can do, which is great because it does provide, some flexibility. And also, if you're really nervous, like I was like, I don't know, 21, and you're like, what happens if something happens to him? What am I supposed to do? So at least you have some backup for a short term, but that's, that's what we did with our money in Ohio. Aging population, again, I'm just gonna continue to bang this drum because this is, it's coming for all of us, the United States, Canada, UK, and the list goes on. As you can see here, as time passes, the share of the population, 23%, half of the people will be using, some kind of long-term care support in their life. And, it's projected that 39% will be using something in a nursing home. So as you can see, though, the share of the population in 2060, it's going to be 23% of the population in the United States over 65. So again, more services for this growing population. There are also nonprofit organizations that do support this as well. Obviously, Alzheimer's Association does that, and they do have their own grant programs in the United States. They may do something similar here in Canada. I'm not familiar though. Not surprisingly, again, this is driven by acuities and complex medical needs. The lion's share, the spending is for people who are over 65 or under 65 with disabilities. So as you can see, that that's a huge driver. Those that are over 65 or under 65 with disabilities have higher Medicaid costs. Again, we're dealing with higher acuity. So FFS is fee for service. So you have fee for service for long-term care, acute care, prescriptions, and then things that are not fee for service or capitated rates. That's, just technical stuff about how things are getting paid for. So you can see that this is broken down by, per member per month spending in Medicaid. This is those with in the DD population. This is just one of these. I talked about waivers yesterday, but again, waivers are basically something where the states apply to the federal government, the Center for Medicare and Medicaid Services, and they ask for permission essentially to kind of modify how they deliver their plans at the state level, outside of the boundaries of the requirements of the federal law. So oftentimes they are, tools of innovation as well. A lot of the waivers are in the space of long-term care support services. 1915C is one of those, and it's a big chunk of that waiver spend. The waiver spending is in the DD population. I've beat this drum a lot here. Long-term care, very expensive, not covered by Medicare. So as you can see here, nursing facilities going up to $108,000 a year now. Depending, that could, the average is about 94. You're still on the top end of really big, issues, complex needs, memory care, et cetera, 108,000. Homemaker services, like I said, those are those kind of like augmented, wraparound services, bathing, cooking, et cetera. Assisted living, we talked about that, and adult day. So it is serious. They use it's a lot of money and not covered by Medicare. Again, why I'm salty about the Class Act. But again, just more visualization here, breaking it down a little bit further about how states have to provide the institutional care, but the other stuff is optional. All other home and community-based services, so personal care, community first choice. That's another one of these kind of money follows the person. If you want to, you're going to go into the community first rather than going into a nursing home and coming out, because that had been a policy in a lot of states where, okay, we know that you need to be in a nursing home because of the ADLs, and then we'll get you out of there and bring you into the community. we talked about the 1915s, which are the waivers, with DD and whatnot. And then 1115 waivers are there. Those are the innovation waivers, like more specifically. So more than half of the long-term care spending pays for the home and community services, but huge variation from state to state. So you can see that this is a representation of the Medicaid home and community-based services as a share of the total, right? So it's a total long-term care budget by state. So you can see that, certain places like Minnesota, for example, over 75% of their Medicaid long-term care budget is being utilized on home and community services. So this is just another representation here, but this is down to home and community-based services versus institutional long-term care supports. Again, remembering that home and community-based services are optional, institutional long-term care is required by federal law for states to cover it through Medicaid. Pandemic, I could not get, do this lecture without touching upon some of this. We all heard the stories, and this was a global issue of individuals in institutional settings and nursing homes, incredibly vulnerable populations, COVID outbreaks, people dying, frontline workers at risk. There's already a shortage of workers in this space. We talked about that in the first slide. And, this is yet another Kaiser Family Foundation study that has recently come out. So as you can see, nursing care facilities and community care facilities for the elderly, continue to, if you look at the change in the health sector employment by setting, I mean, it's a precipitous drop, comparatively. But home health care, you can see outpatient. It's a serious issue. Again, this perfect storm where there's increased demand for these services for a number of reasons, but because of workplace risks, lack of competitive pay, the workforce is not there. But again, creating this perfect storm. So, we don't need to belabor this. We know this, but this is a pretty stark. If you look at 2% of the population are people that are in long-term care facilities as residents or staff, but they comprise 21% of the COVID deaths in the United States. That's a pretty stark number. And again, people wonder why, we have a shortage in this area, and how do we get people attracted into this space? So, contemplating some of these lessons, trying to bring it back to the Canadian context. I want to kind of open it up to anybody here or on Zoom. We know that we share shifting demographics, rising costs, strengths and weaknesses of federalism. Not all provinces cover the same things, whether it's prescription drugs, long-term care, dental and vision. So, the United States, oftentimes we look to Canada as like, oh, it's so, it's great because you guys actually, everything is covered. And no, it actually is not. And like people like my students and others, like, their mind is blown. Like, what do you mean? Like, it's like, look, the provincial stuff is not far off from what we deal with in the States. State by state, province by province, you're dealing with different types. I mean, yes, you have your federal health transfer and some of that bilaterally. And I know that that's happening right now with, between Ottawa and the individual provinces, trying to tailor, some of these health transfers to the needs. And I long time ago, I had a chance, I went up to New Brunswick and I met then Premier Brian Gallant, and he at the time had also been trying to advocate because New Brunswick, older population, what can we do to get a health transfer that's better? Bottom line is we both have strengths and weaknesses when it comes to federalism. you have some flexibility, BC is not the same as PEI, fair enough. Washington State is not the same as Florida, fair enough, but there are strengths and weaknesses. So, the question that I would pose is, should the role of the federal government change as it relates to the funding and oversight of long-term care support and services in Canada or in the United States, given what we know about these, nationwide challenges of shifting demographics, rising costs, and some of the, potential limitations or challenges or inequities, frankly. And we haven't even scratched the surface on our First Nations and Indigenous folks, which is a whole other ball of wax, which I will be talking about later tomorrow, that I'm very, very passionate about, because you want to talk about two-tiered system. That's a two-tiered system. I'll just give you one small anecdote and then I'll open it up. When I spent a couple weeks, a number of years ago, volunteering on the Blackfoot Reservation, Blackfoot Nation in Northwest Montana. And I did a bunch of different stuff, but because my background is health policy and healthcare, and I'm a social worker too, licensed social worker, I spent a bunch of time in their nursing home. And I ended up, because I thought I was just going to be hanging with the elders and doing stuff. No, I ended up hanging out with the nursing home administrator, trying to figure out how we were going to get donated wheelchairs and walkers. And the way that the Medicare contracts are with the Indian Health Service, personal care allowances, which are built into nursing homes, don't really exist. So the administrators are paying out of pocket for Depends and shampoo. And so I'm scouring. So I spent a week scouring the internet trying to figure out how can we get things donated in a way, because for the staff, it's how we hear about teachers paying for school supplies, similar kind of thing. But so the fact that elders in Indigenous communities in institutional settings don't have the personal care allowance in the same way as people off the reservation is just one example of the two-tiered system that exists in every level of, Indigenous and First Nation stuff. But so I'll open it up. How do I find the folks on Zoom?
Yeah, thank you. That was excellent. Thank you so much. I'm just going to close this also. Maybe I'll stop share so we can all see each other.
Fantastic.